She is a professor of radiology and a fellow of the American College of Radiology and the American Society for Functional Neuroradiology. She is currently doing her doctorate in artificial intelligence-based analysis of head and neck and skull-based pathology using 7 Tesla MRI. Dr. Kirsch is an excellent educator and innovator. She's received numerous awards for developing educational software and new MRI techniques, and we're excited to hear from her today.
Well, thank you so much, Reza, for that lovely introduction. I get to wear a lot of different hats, so I kind of love the opportunity to do the things that I get to do, but my favorite opportunity, to really be honest, and I got to work with a bunch of our residents and fellows this past week, sitting side by side with them, is teaching. And to me, it's like really a privilege and an honor. You guys are our next generation coming forward, who are going to be kind of developing the stuff that we do. And I'm a little bit unusual. I am a full professor already at Yale, but I wanted to go back and take a deeper dive into understanding things that I didn't understand. So, and if I can do it, anybody can do it, is my philosophy. So I did it finding different mentors, and I'm now about literally, as we speak, submitting in my final thesis coming in, and we have some publications. So without further ado, let's dive in. I like to start my talks by acknowledgements. Many people put them at the end. I think it's really important to acknowledge at the beginning. And I have a different team, and people kind of wonder about that, but it's unique because there are these people doing this work that aren't really doing it elsewhere. The University of Sheffield is the first one with the neopath.org, which I'm part of, that really looked at AI, looking at head and neck pathology. Dr. Lambert's an expert in ACE2, and we'll show some of the work that we just published on that. Dr. Harpreet Herrera is a neuroradiologist, also MD, PhD, who did viral work in virion pathology and prions. And Dr. Balanchani is fantastic. She is our leader of the 7T lab that I work with at Mount Sinai. We are building a new one at Yale, where I'm at right now, but I'm adjunct associate there as well. And of course, I need to give a huge shout out to Dr. Reza Murden, who I saw at the SFNR, and I think one of our colleagues who has now joined your group, Dr. Miriam Obian, who's also doing fantastic work. And I'm honored to be part of this BRATS Lighthouse Challenge. I do think it's interesting that, we had kind of a BRATS summer. This is a slightly different BRAT, as we know of, but I hope with these lectures that they will become cult classics and you guys learn from them as well, as was from the BRATS summer. So let's dive in with a few things I have to declare before I begin. All my disclosures. So I helped develop a head and neck imaging educational software. Feel free to scan anything on a QR code that I show here. It's something I've worked on to develop. That includes Primal Pictures. I get royalties for that. So if you see any of these illustrations or diagrams or the videos that I show later on, that's part of the Primal Pictures head and neck anatomy that we help develop. I'm also under several key grants that I need to acknowledge, including several NIH grants. We are submitting for an additional R1 that I'm putting in for right now. I've just completed an ACHNR educational grant. So you can just type in lotstoswallow.com, and it's all educational stuff for free for you guys as well. I've also received grant funding from my own department, so I'm very fortunate and lucky to be given the time to do the things I do. I inherited when my father passed away Care Medica. That's developing. He ran an NIH lab, and because of that, I inherited that, so I have to declare that as well. But most importantly, some of these things slightly relate to what I'm doing, because I'll show head and neck anatomy. Obviously, the grant work from the NIH is clearly the work I've been doing that we're continuing on, and they would like me to submit for additional stuff that I'm working on, but those I'd need to declare at the start. So let's dive in. And we're going to talk about viruses. And the reality is, when I dealt with the COVID pandemic and I started looking at stuff, I was actually already looking a lot at HPV and looking at EBV. But like Maya Angelou once said, I learned that I still have a lot to learn, especially understanding how they affect the head and neck region. And so when we look at the SARS-CoV-2 and when we look at HPV and EBV, there's a lot we still do not know. And it was enough for me to say, I really need to understand this. And I'll tell you the real kind of impetus that really drove me. It's like, what, I'm doing this is when the SARS-CoV-2 epidemic hit here. I was actually in Australia speaking actually about HPV, EBV viruses. And I flew back to New York City and I got COVID pretty bad. That was in the beginning of the pandemic here in March. I was very sick, and sick enough that they teed up a respirator for me, and I refused to go into the hospital. I proned. I was literally couldn't move my head or get up. I had fever spiking for 10 days. It was pretty hellacious, but I survived. After I survived, they set me up with a home workstation. And that following, I'll never forget it, that first weekend of April, I said, I'm fine, I'm okay, I'm over the COVID. I can read cases, put me on call. And on that call weekend, I'm not kidding, every single case I read was either a horrific stroke or a brain bleed or just huge inflammation, and people were dying. And they were young people my age. I had a bit of survivor's guilt. I'm like, wow, I'm okay. Why are these patients not okay? What the heck is going on here? Like, really, what the heck is happening with this virus? And it really prompted me to understand it. We wrote some of the first papers that on COVID causing venous thrombosis, and I've now still remained kind of fascinated how this virus is affecting what we see and do. So in this time that I get with you today, I'd like to kind of share with you some of the work that I've been doing. And again, anything that's a QR code, it's a paper I published or something I've worked on, feel free to scan it, or I'll be more than happy to send you the papers anytime. And I thought, okay, I'm a neuroradiologist. We need to understand what's happening, and can we use imaging to really quantitate the pathology I'm seeing in the skull base and head and neck? And that includes HPV, which we know is the #1 sexually transmitted disease worldwide, leading to the leading cause now of oropharyngeal cancer. And we know that it behaves and has different subtypes. We know that EBV is a leading cause for both nasopharyngeal carcinoma as well as demyelinating disease, and of course, SARS-CoV-2, which has many effects inside the brain. And we know it causes increased incidence of seizures and thrombotic effects. So really, how can we use imaging to understand what this virus is doing? But let's take it a step further. Can we understand how this virus is getting into these tissues and then causing these disease processes that we're seeing? And then can we also quantitate the imaging response? Can we see how things are being affected? And then can we then have a biomarker to see what's happening? And then lastly, can I use techniques such as artificial intelligence to help me see things in the brain that I might not appreciate with the naked eye, that helps me better understand the disease process? And the answer is yes, with a resounding yes. These are publications that we've just come out, and we just had one last month that I'll show you. And to me, that's really important, because our goal is to help patients. And the better we understand these disease processes and how they're affecting the body, the better we can then follow patients and then treat them over time. So let's start with HPV and the tonsils. If you come to our tumor boards, head and neck, you'll often see that it loves to go to the reticulated epithelium of the tonsil. That's its favorite spot. And often it's a small tonsillar primary with large cystic lymph nodes in the neck, as we see here. And the majority of these patients have a better outcome. But we have patients that we've seen on our tumor boards, and as I show here, that have a terrifically bad outcome, meaning they've got aggressive mets everywhere and then high morbidity and mortality. And we treat them all the same, but they are not the same. And in fact, there's now basically different subtypes. And in the research we did, we found that of these HPV subtypes, there are some that have alteration in the Notch tumor suppressor, and these look different on imaging. They look more like a small cell carcinoma, and they behave more aggressively like a small cell carcinoma. And we're working to quantify those as well. We've also now been looking at sinonasal, and we have a collection of cases that we're just starting our research on, where they used to be classified as an adenoid cystic. In retrospect, they are not adenoid cystic. They're like a multiphenotypic. They look like an adenoid cystic, but in reality, they're HPV-related tumors causing these tumors in the nasal cavity. And we're analyzing those. Importantly, we've also reported and seen that young patients are presenting with an oral cavity squamous cell carcinoma. Now, I want you to think about this. You guys are pretty young, but it used to be, if you looked in the literature prior to like 2000 or even in the late 1990s, it was reportable to have a child having a squamous cell carcinoma in the head and neck, because it just only happened if they had a severe, genetic defect like a Fanconi's anemia or a telomerase deficiency. But we were seeing children come in who did not have any of these genetic abnormalities, as in this case here, who had a squamous cell carcinoma. There was often a delay in diagnosis of these tumors because nobody can imagine they've got a squamous cell. They think it's infection or something else. And what we believe is going on is that when the child is going through the birth canal, you obviously get exposed to the HPV virus. When the teeth fall out and you replicate, because it likes to go to the basal tissues, when they lose a tooth or they get a new tooth coming in, it goes into those deep tissues, as we see here. And this was a case that we had of a squamous cell carcinoma in an otherwise healthy child with no immune abnormalities, and there's an increased incidence. So this case actually has a very good outcome. We can see it here in this post-contrast. It was resected, and he's done very well. So we're now taking it a step further, and we want to look at these tumors and, most importantly, create what I consider is important, create registries that we need to share with everybody, because the numbers aren't huge on all of these cases, but if you share that data, you'll get a less biased result. And these are cases we're now developing where we have the ability to do pyradiomics and analyze that and then share these in a series of tumors. So we're now creating those databases, and we're working that in our lab. Additionally, I want to highlight that we have new immunotherapeutic agents, especially for treating head and neck cancer. This is another grant work that we just finished this past year or two ago, where we've looked at the response to these immunotherapeutic agents, and it has been very good. Nivolumab and these other agents with anti-immune response. And I think this is another area that we need to follow very carefully as we can treat these tumors in advanced stages. They're proving to have better outcomes. But we need to understand why some respond and some don't. And this is recent work that we just published on in that area. So I want to spend a little bit more time diving into the EBV virus. And Epstein-Barr virus is a fascinating virus. And we now know, even though I'm a head and neck and neuroradiologist, that this is the leading cause of demyelinating disease. So I want you to think about that. This is a virus likely causing, from the Harvard Chan study where they looked at a bunch of military recruits, the leading cause for multiple sclerosis. And we know that the biggest risk factors in this are likely childhood obesity and lack of vitamin D. And I think there may be reasons for that there's an immune response to the fat that people have in their body that then leads it to the brain response we see. So let's dive into this virus a little bit more. It's a herpetic virus. It has been around since the time of the dinosaurs. It is a huge virus. It's about 170,000 base pairs. It has 85 genes. And if we take a look at it, there's different subtypes. In Africa, it's mainly the EBV2, but the other one that we have here, most of the world's EBV1. And let me tell you, it is incredibly infected. Anytime you touch something that has it, then you touch your face, you're getting infected. It goes into the B cells, the T cells, the epithelium, any secretions that have it, you're getting infected. The reality is, all of you guys I'm talking to, 98% of us right now have an EBV episome in our B cells just hanging out. So it's there. Now, why is it so successful? Well, once you get infected by EBV, and we've all probably been exposed or we have it and as an episome, that little episome is hanging out right now in your B cells. It's just hanging out biding its time. It waits until it has a good opportunity to replicate, meaning if your T cells aren't working or your immune system can't keep it in check, it then replicates. But when it replicates, it uses 90% of your host mechanism for replication and only 10% of its own, meaning the proteins that are exposed on the outside of this viral capsule are your body's proteins. So clearly in obesity or lack of vitamin D, which is a fat-soluble vitamin, there is some fat exposure or protein exposure which mimics a myelin protein, which then leads the immune response to attack it. Because now it's exposing itself, it's hiding like a wolf in sheep's clothing, your own proteins to your immune system. So to me, that's where the problem is occurring early on. Why that then happens in some patients and not others, we don't know. We clearly know that depending on which region that you live in, if you don't have enough vitamin D and maintain the immune system, it is a very key area for research. Now, we do know that when it gets activated in certain phases in young patients, even in patients who are of African descent who are not from Africa here in the US, we can see it get stuck, that germinal center, activating the c-Myc oncogene, and can lead to a Burkitt's lymphoma. And here you can see in this Burkitt's lymphoma that you often have higher density because of a higher nucleocytoplasmic ratio of this, and this tumor is very aggressive. It has perineural spread. As we see here, it's replaced the marrow completely on this coronal T1 post-GAD MRI, and then can have perineural spread, which we publish, which is classic. So we see it growing here from the nasopharynx, even recently published in pediatric patients, where it can then track up and go through the V3 opening into the cavernous sinus. So these tumors are more responsive when they're EBV related to treatment, but we clearly know it's an activation of the virus inside the system. Now, in certain subtypes, especially in Asian males or in people in North Africa, they actually have higher titers of IgA to these EBV structural proteins. And we know that, again, it can go through. And what's important is when we see it in the nasopharynx region, it often can track through an opening laterally along the pharyngobasilar fascia, which we've documented on and looked at and then published on. But what's interesting of the mucosal tumors, this is the most common nasopharyngeal tumor in adults in middle age. Again, the EBV is non-keratinizing, often is more radiosensitive with a better prognosis, compared to the tumors you can get from smoking or tobacco and alcohol, which are more keratinizing and have a worse prognosis. So areas of still that we're trying to understand how it gets in here and does that. So I've been looking at EBV quite a bit because I believe we know it causes MS, and we've been looking at different ways of evaluating MS. We're doing a lot of AI analysis here. There's some recent work was just published by Dr. Bowen and Dr. Davis here at Yale comparing different software types. And we know that we can see MS obviously attacking anywhere in the brain, leading to visual loss and problems. So we've been looking at MS, but one of the key factors we know, again, is obesity. Now, obesity is not just a risk factor for MS, but it's a risk factor for other problems as well. And this is something I hound to my trainees all the time, which is if you see a partially empty cella, you should look at how big your optic nerve sheaths are. If they're bigger than 6 millimeters transverse, now you're probably dealing with idiopathic intracranial hypertension. And you can see the papilledema. We're the first ones to see this on imaging before they even do a fundoscopic exam. Because the brain is so tight, it will flatten it on portions of the transverse sinus. And we know that we can analyze the brains in these patients with the AI. So we are literally about to publish these 2 studies that we've just completed. One study we looked at looking at AI with different techniques to see the opening pressures, and it had a very strong correlation with white matter volumes, which appear to increase. And we also know that you can develop defects from arachnoid granulations, which can lead to small defects, especially in the temporal lobe region and along the skull base. So normally your skull base should look nice and smooth. Here's foramen ovale, looks like the front of a nice, sharp, fancy lady's shoe, spinosum, and a little spiky heel. But if you look at somebody with idiopathic intracranial hypertension, it looks like they took an army boot, and this is a patient you can see, and they develop all these aberrant arachnoid granulations, which have a higher risk for CSF leaks. And if those become infected, a higher risk for morbidity and mortality in those patients. So something very concerned about. So we're talking about viruses and immunity, right? So the key question is, how does that immune system react in there? So we can see it takes that antigen, gives it to the helper T cells, and then will affect those helper T cells and the memory cells. And then will affect the cytotoxic cells. And that, in fact, will then affect other things. So we can either then kill via normal inflammation in the classical pathways, or it can do it because of something called opsonization, causing cytolysis. But what's interesting to me when we look at patients who were hospitalized in the early COVID epidemic, the actual viral titers were lower than those patients who weren't hospitalized. So it wasn't the overload of the virus itself, it was the immune response, which was causing a lot of problems. So let's think about that for a moment. If you have a overexposure of high viral particles, and think about this, we were intubating patients, we were not really cleaning those machines very well, the hospitals were loaded, it was in the air, you were really, a lot of viral particles were coming in on patients, you were overwhelming that immune system, you would cause severe inflammation, and you would basically get overwhelmed, and these patients had a marked, basically sending troops in all directions in the immune system and did very poorly. But if you had just a little tiny bit of viral exposure, enough to mount a memory immune response and be prepared, so the amount of actual viral exposure played a role, those patients had protective immunity. So the actual dose of exposure at the very beginning played a role as well. So let's just talk a little bit when we talk about what a virus does and how it comes in. We can have something that's neuroinvasive, right? That's the ability of a virus to come in, infect the nervous system, especially the central nervous system. And if it's very neurovirulent, this will cause disease in either the peripheral nervous system or central nervous system. So let's take a look at something that's neuroinvasive. Polio is weakly neuroinvasive, right? It's not diving in onto your nervous system. It's not jumping in there. But once it gets in, right, if you're not vaccinating, you drink contaminated water, it is highly neurovirulent, meaning if you get it the fecal oral route, it will go right into the nervous system, and it tracks back and goes to the anterior horn cells, as we see here on this sagittal and axial T2 of the spinal cord, and literally attacks those anterior horn cells, and you lose the ability to move. We really only discovered what this virus looks like, and it's a picornavirus, which basically stands for polio insensitive to ether, coccidiovirus, orphan virus, rhino, and ribonucleic acid. And it wasn't until that we, in the 1990s that we actually discovered the actual molecule here. And this is in 1986, where we actually got an electron micrograph to see what that virus looks like. And you can say, well, Dr. Kirsch, polio, we're fine. No, we're not. If you take a look at this virus, which has marked icosahedral symmetry, as recently as the past few years, it has been detected in the wastewater, which is why vaccination is critical. It was before our time when they had the iron lungs, but it's critical that you have vaccination against this, because the last thing you want to do is lose the ability to move for the rest of your life from a polio infection. So it's been now rediscovered in parts all over the US and in the wastewater. So it's still with us. It hasn't gone away. So that's just a heads up, because we might be entering a very unique era for the next 4 years, and why vaccinations are so critical. What about rabies? Again, rabies is weakly neuroinvasive. It's not jumping in, coming in there and weakly getting into the system. However, if you have a cut or a break in the skin and you get a bite from something that has rabies, once it gets into the nervous system, as we see here on these axial flare images, it is highly neurovirulent. So here you can see this abnormal flare hyperintensity involving the caudate heads, the thalami, into the temporal lobe region. And it's a bullet-shaped virus, right? So it's a mononegavirus. It's got a negative stranded RNA. It looks like a bullet. It's a bullet coming right toward the brain, highly infective. So it's imperative to be kind of vaccinated against this. So if we think about how viruses come in, it's important to understand that blood-brain barrier. So let's dive in a little bit more into that blood-brain barrier. So we know that if we look at this blood-brain barrier, you have this parasite layer. Coming around that parasite layer, you've got a basement membrane around your vessels, and then superimposed on that, you're going to have astrocytes, right? And these astrocytes all have little end foots that kind of come together. So it's very tight, it's difficult for a virus to get through here. The other thing we have, and important to think about it, is that your brain's constantly cleaning itself out, what I call the cartage or garbage system cleaning of the brain, or G lymphatics, meaning after you produce this stuff, your brain kind of tries to wash stuff out of there every evening, and you do this while you sleep, which is why sleep is so critically important. So you have CSF, and you have perivenous influx. It's going to go up into the lymphatic drainage, and that lymphatic drainage often goes up to the superior sagittal sinus, but it drains, which I always find fascinating, right into those incredibly important skull base retropharyngeal lymph nodes, which we know get infected with EBV virus, and we also know our tonsils right in the same region as where HPV goes. So they're very deeply related, both the brain and the skull base and that G lymphatic system. An important thing to really think about. So now let's talk about SARS-CoV-2, because SARS-CoV-2 is still with us. It's caused over 7 million deaths, and we know a lot about it. We know that it's going to invade your cells via this protein on the outer portion of the capsule called the spike protein. And that spike protein is going to specifically bind to an ACE2. And this is a 3D replica from science of what the ACE2 receptor looks like. It literally binds onto ACE2. So the virus can only enter a cell that has an ACE2 receptor, and that's really important. We know that once it comes into the cell, it's then going to use that cell's own replication mechanism from the endoplasmic reticulum to replicate a bunch of other viral particles. But it cannot enter unless those cells have that ACE2 receptor. So once it's in, it starts replicating. So let's look at that spike protein in a little more detail. It's got a little flexible hinge, kind of like your shoulder, your knee, kind of a flexible joint. It has a receptor binding domain. That's what RBD stands for. And if we look at this, it's encased in that lipid bilayer on the outer portion of the virus, and it's coated with glucose. It is a sticky viral particle. So if you're touching a coin, you're touching something, then you touch your face, you're going to infect yourself. In fact, the best way to prevent infection is to keep your hands below your waist at all times. Like seriously, they've done studies on this. It's just don't touch your face, which is virtually impossible not to do. The moment I say don't touch your face, somebody now is like scratching their eye or touching their face. We just do it all the time. But we know that that glucose molecule is important for several reasons. Why is that? Well, we know it's going to bind that spike protein to the ACE2 receptors. I know if I have patients who have elevated glucose levels and also obese, they're going to have higher inflammatory markers. So if I've got a diabetic patient, these are the ones who did the worst, or obese patient, they're going to do poorly because this sugar helps facilitate the antiviral activity. It kind of decreases that glucose, facilitating viral replication and infection. And importantly, it disrupts my immune system because I have an increased inflammatory response with cytokine storm, especially in patients who are diabetic. And we know it acted synergistically with the SARS-CoV-2, escalating multi-organ failure and thrombosis. So elevated blood sugar, like when you look at your hemoglobin A1C, is a key thing. Now, I'm very curious to see what happens with Ozempic, because Ozempic not only facilitates weight loss, but it also reduces hemoglobin A1C levels in diabetics. So we might see something turning around. I know that eventually with these trizeptides that there is newer agents that are going to come oral, and that might change some of the stuff we're seeing with obesity and diabetes in your generation, which will be very interesting to see over the next few years. And we've been doing research as well, looking at the hypothalamic region. That's another talk for another day if you'll have me back. So this is some of the early publications we did looking at SARS-CoV-2. We know that it would, number one, go to peripheral vessels. There's ACE2 receptors on those vessels, and it would lead to thrombotic effects, right? And we also know it could go into the brain parenchyma and cause a cytokine storm. So you have a double whammy. These are cases that we saw with patients who would either infarct, literally forming thrombosis in vessels as we were watching them on the angio table. It was pretty horrific. Or we could see this diffuse, irregular inflammatory change along the brain from this virus. But here's where I'm really puzzled and working on it. We think we might have figured out, but we'll show that paper to you in a little bit. How the heck was it causing anosmia, which was a leading problem in that first portion of the epidemic? So let's think about the sense of smell for a moment. We know how hearing works, right? Dr. Von Besky drilled a bunch of pigeon ears, and he realized that if you look in those rooms, your cochlea is basically laid out in a topical pattern that depending on where you stimulate that cochlea, you can hear my voice with different frequencies. So it's frequency modulated. We know that vision, same thing, my colorful slides, you can only see within a visual spectral wavelength of certain frequencies because it's going to activate your rods and cones, activate the rhodopsin, but again, it is a limited visual frequency that you can see. So it's frequency mediated. But when it comes to smell, which is one of the key senses affected by the SARS-CoV-2 virus, we don't even know how smell works, right? So if I don't even know how something works, how am I going to figure out when it's pathologically abnormal? We know that you smell a molecule, right? The first thing we do in the morning, we shower, we try to smell good, we drink our coffee, it smells good. But how is it activating this olfactory nerve so I can smell something? We have no clue. You can say, well, Bucks and Axel received the Nobel Prize. They received it for the genetics. They never described the mechanism. So we know it activates certain proteins, the CMP, but I don't know how that activation in the membrane is occurring. Is it the shape of the molecule? Is it frequency mediated? Is it quantum tunneling? I am actually doing research on this right now, and I have a meeting with somebody literally right after this where we're looking at the connectomics, and I'm looking at this right now, and I have a theory. I'll have to share it with you later, but really excited because I'm literally working at this next several papers that we have coming out. We do know from recent work that was done in insects, which have an incredibly sensitive sense of smell. You have this almost kaleidoscope appearing set of receptors, and I personally have my thoughts on how it's done, but we'll share that for another day. What we do know, though, is olfaction is critical in neurological diseases, and it's one of our key senses of joy, right? You smell your coffee in the morning, it makes you feel good, it goes to these regions in the brain that are going to make you happy, right? So I love studying olfaction because it's fascinating. We know we can see these anatomical cavities on MRI beautifully, right? You can see the little olfactory stria, you can see the olfactory bulbs and tracts, and you can see the little medial and lateral stria. And we can identify these beautifully on high-resolution MRI and even nicely on 7T. So once we can see these pathways, we can study them. So we know in the cases we looked at that had previous imaging, that we saw that in patients who had anosmia or loss of smell or abnormal smell, we could see the loss of the tracts on the olfactory tracts and bulbs. We could visualize that predominantly in female patients and usually Hispanic or Latino, which if we'd done more correlation, I think was due to diabetes and elevated body mass index. And all these patients had volume loss, and that's been reported by others along with edema, microhemorrhages, and enhancement. But here's what always bothered me. Here's my viral particle coming into the nasal cavity, going in, being absorbed, and clearly damaging, causing faulty wiring because we're losing the sense of smell or having abnormal smell, distorting it. I'm losing volume tracts in the olfactory bulbs and tracts. But as I told you before, the only way that virus gets in there is via ACE2 receptors. And there's no ACE2 receptors in this olfactory bulbs and tracts. So it drove me nuts. Like, why on earth is this happening? How is it affecting the olfactory bulbs and tracts if there's no way for the virus to get into that tissue? And also, it would go into the brain pretty quickly. For it to transfer along the olfactory bulbs and tracts takes about 2 weeks. So it didn't make any sense to me. So I'm going to teach you some anatomy that you may or may not have heard, but you're going to learn about it now. This has been around. These are the actual publications since 1914 of the nervus terminalis. It was officially designated in 1988. These are thin neural branches. They're often right adjacent to the olfactory tracts and nerves. They go into the hypothalamic region. They're associated with gonadotropin release, and they're heavily involved in the immune response. They release nitrous oxide. They help with vessel dilatation as well as constriction. And here's the fascinating thing. They are loaded with ACE2 receptors. So clearly I'm like, oh my God, they're there. Can we see them? So the first goal was, yes, you can see them if you know where to look for. We know that they're always along the olfactory bulbs and tracts. This is, pathological studies that have been published on this. And we look in the OR, you'll see them right along the olfactory bulbs and tracts on cadavers. But they're often not taught in medical school, and there's very little inclusion in the medical literature, and they were not even published in the imaging literature until last month by, you're looking at who's talking about it. So what's fascinating as well is that they're also found in whales and dolphins that don't have olfactory systems. They're in all vertebrates, which I thought was fascinating. We actually imaged brains of dolphins. Okay, we didn't kill the dolphins. We didn't hurt them. These are brains that are in specimens, but we actually imaged them in our 7T lab. And obviously these fibers are present, but they don't have olfactory systems. So they're present in everything, but we didn't hurt any dolphins. I just want to clarify these were specimens that we imaged. So the first goal was, can I see these little tiny fibers separate from the olfactory bulbs and tracts? And the answer was yes, they're there. I can see them on 7T and I can see them on 1.5 and 3T. So then I was like, okay, can I see if there's changes in the olfactory bulbs and tracts in patients with known anosmia? And the answer is yes, I can see the bright T2 signal. So we did this work and then we presented this nationally and we were very excited. Yes, we can see them. Yes, they are clearly there. We just never paid attention or reported them, but you can see them in all the studies. So then we took it a little bit further and we said, okay, is this a potential point of entry site in patients who have COVID? And more importantly, we have a series of autopsy brains at our institution. And I went back and looked at this autopsy brains and you can see the little fibers on those autopsy brains. And then we went back and analyzed all our patients with known COVID changes. So here you can see the little olfactory bulb, which is abnormal and brighter. Here you can see the normal side, and you can see the little adjacent nervus terminalis. And we said, are they brighter? Is it being affected? And we analyzed all of this data pretty intensively, and the answer is yes. So we literally just published this. Some of the leading work also was reviewed by the people who work on these ACE2 receptors on the nervus terminalis. So this paper has just come out. So we believe, and we need to prove a little more research on this, and we're putting in for the NIDS wants us to put in for another R1 grant on this, that what happens is when you're affecting these little fibers, they're controlling blood supply to those olfactory bulbs and tracts. If you're causing inflammation and damaging that blood supply, it's like a little stroke to the olfactory bulbs and tracts. And those tracts can regenerate over time. They take about 2 to 3 months. And in most patients, 80% they do, and they regain that sense of smell. So it may be causing and altering the blood supply getting to the olfactory bulbs and tracts. So these are images that I want to show you. This is a normal. We could see beautifully these little olfactory bulbs and tracts, and you can see these additional little neural fibers These are different than the little flow voids that we see on vessels. And we're now sharing our details of how we do these sequences with many other researchers around the world. We'd love for them to do the similar work, but they are there. So whenever you're now looking at a high-res image on 3T, I want you to look carefully and say, whoa, do I see these extra little fibers? And you're like, oh my God, they were there all the time. So then the key goal was, do we see them altered? So here we see a nice example, olfactory bulb and tract, abnormal signal, and then it becomes very faint, but it was abnormal in the cases, and we could see enlargement of the olfactory sulcus, specifically in patients with known anosmia and hypoglycemia, loss of taste and smell. So the answer was yes. So we're very like, wow. So the next step we'd like to do is, obviously, we're doing now connectomics and tracing these pathways into the portion of the brain that they're innervated. Because clearly, if they're damaged, those additional kisspeptin neurons, those key nervus terminalis neurons, if they're damaged, they're going to then affect those areas they innervate, which include to the limbic region, the temporal lobes, the entorhinal cortex, and to the hypothalamus. We also noted in patients who were coming in that there was a higher incidence of seizures, either in both hospitalized and non-hospitalized patients. And these are 2 studies we published. And that makes sense, right? Because my olfactory tracts and bulbs go right to my hippocampal region. So smell and memory are intricately related. And what's fascinating when you think about your temporal lobes is the protein encoded in your hippocampus is something called encoded by the ARC gene. Now, this ARC gene was probably encoded some viral ancestors some 400 million years ago, because if you look at the protein, it looks just like a virus. So this capsule is really key, because this little thing is transforming your memories, helping you remember this lecture between your neurons. We do know when it's damaged, right? If you damage this little area here, we see that ARC protein is affected in things like amnesia, Alzheimer's, autism, and Fragile X syndrome. So if you have a virus that's coming in and interfering with the production of this protein, you might develop seizures or memory loss or some of the changes going on. We also looked specifically at long COVID brains. And we wanted to know, is there a difference between normals versus long COVID? And we did AI analysis, and we found that there was, especially the perivascular spaces were markedly enlarged like Swiss cheese. I now have a collection looking at the perivascular spaces. I believe they're involved in the G lymphatic clearance, where I see them enlarged in patients with seizures, Alzheimer's, post-traumatic brain injury. Go back over time and follow them, and you'll be like, oh my gosh, they are enlarging. And it could be due to impaired G lymphatic clearance from either inflammation or post-traumatic, hemosiderosis affecting that area. And here's where it gets really fascinating. Now we can all have meetings and be without masks because we have vaccines, right, that are protecting us. But if we look at these patients, we had a patient who came in who'd never had COVID, antibodies all negative, but only got a certain type of vaccine. And they came in complaining of phantasmia, smelling this burnt rubber smell. And in fact, when we looked at the brain imaging, they had volume loss and the same changes in the olfactory tracts and bulbs in the same region of my COVID patients. So we published this work, and now people around the world, this is another paper, if I just had more time and hours in the day, another paper I'm working on, where I have a collection of these cases, all with the same findings and the same type of vaccine with volume loss. So it could be that inflammation to that ACE2 receptor, again, likely on the nervus terminalis neurons, causes some effects of the blood supply going to the olfactory tracts and bulbs, and then over time it will regenerate. And interestingly, all of them complained of the same type of smell and kind of phantasmia, and it was always the same type of vaccination. So I always love these letters I'm getting. I have a collection of them and a collection of these cases. The other thing we noticed, of course, is that when you shut down things that people needed, like dental care, the number of dental infections in our ED markedly rose. We received a research funding for this study, and we reported this. It's already been published. And these dental infections could lead to pretty severe consequences. So I like to remind every trainee, teeth can kill. I always make my trainees look at the teeth, because bad dental infections can track up the fascial planes, leading to orbital infections, can go to the cavernous sinus. And we saw, especially in unique socioeconomic areas, that were really affected by this. And we've published on this work this past year. So I want to kind of re-summarize all this information that I've given to you guys, and it's a lot, I realize. So we wanted to quantitate, how we look at head and neck imaging, and can we use that in viral diseases? And we're looking at with obviously HPV and again EBV. And clearly we can use that as well as using advanced AI techniques to help us see things in the brain that we might not appreciate. And that includes alterations in volumes that we see with idiopathic intracranial hypertension, which may predispose, if you're obese, to infections not just from EBV, but then secondary infections if you develop aberrant granulations and leaks along the skull base into the temporal region. Can we use imaging to help identify key viral sites of entry? And the answer is absolutely yes. If you start paying attention to what you're seeing, you might notice additional findings on that imaging that you have to quantitate. And then clearly, can we use imaging to give us biomarkers? Can we follow disease progression and understand what's happening? And the answer is clearly yes, because imaging can show us what's happening, and then we can follow it over time to see what's going on with that area. So I like to think about it this way. 8% of our DNA is basically viral DNA patched in over retroviruses over evolution. So whether we like it or not, there are more viruses out there than stars in the universe. In fact, they're the most abundant microbe on the planet. There's over 10 to the 30 viruses in just oceans, particles alone. It's all around us. But they need that special lock, right? They've got to have the right key to enter the door. It's like if you go to a hotel, if you go to your home tonight, only you have that key to enter that door. And we know for the ACE2, for the SARS-CoV-2 virus, the ACE2 was that special key, right? It had the lock, go in the key. Most of them are out there harmlessly doing their thing, but if they can fit in and get into your genome, they will do so. And whether we like it or not, each of us is about 1/12 human endogenous retroviruses. So my feeling is we better try to figure out and understand them to better understand the diseases that we're seeing on imaging and hopefully treat the patients who have these diseases that we look at. So I always like to end my talks with a quote, which as I do AI and I see more things that I never saw, disease is very old. Nothing about it has changed. It is we who change as we learn what was formerly imperceptible. And I think AI and high resolution techniques are allowing us to see things that we didn't perceive before. This is my family. I enjoyed the opportunity to speak to your Bratz family and imaging group there at CHOP. Our newest family member is Leo. This is him when he was literally about 6-7 months ago, and this is him right now. So I hope you grow and learn during your training as much as our fellow has done. And I will now end right there and give a little bit of time for questions from everyone. So thank you so much for having me today. You need to unmute.
Oh, sorry. Thank you so much, Dr. Kirsch. That was amazing. I learned so much. I do have one question.
Of course, and I think other people have their hands raised too, so please go ahead.
Yeah, so how close are we to having this type of imaging in clinical practice, and at what stage of a patient's healthcare and symptomatology would this type of imaging come into play?
Great question. So right now, many 7T scanners are basically research-based, so that's a problem, right? Not all academic centers have them, but many places do have a 1.5 or 3 Tesla, right? So if you look carefully, you can see with good quality imaging and with good sequencing, and I have to say lower field of views and dedicated sequencing, you can see these findings. So we are trying to design our, we did the 7T for the perivascular spaces on a 7T, but now we're trying to design the algorithms so everybody can use them on a 3 or 1.5, because most clinical scanners have 3 or 1.5. It's just you have to really tweak the sequences to give you that resolution. Now we'll always see more on 7T because a higher signal to noise ratio. I do believe that we will improve our ability to see things better using techniques, especially with AI, on lower field magnets. So over time, I'm hoping we'll wait and see, though, right? It's the predictions of things always aren't as hopeful or fast as you would like they to be. I can't see all the questions, so I'll let you just everybody who's there just unmute yourself, and I look forward to hearing all the questions.
Yeah, thank you so much. Mohanna, do you have a question?
Yes, thank you so much for this mind-opening lecture. It's more like I'm speaking my mind off. Is there something like radio labeling live attenuating viruses and following them?
Absolutely. No, that's a great question. And yes, people are doing that in animal models. We are using some places now are trying to use viral particles for treatment of brain tumors, and you can radio label. So there is ways to do that. I haven't done that. That you need like an advanced radio labeling lab that's a little more expensive, a little bit more work. I'm a firm believer in like using the tools I have just to see with what I've got without doing other expensive, fancy models. But absolutely great question. And I think that's a whole new area of medicine that's coming in as we understand, looking inside the nasal cavities, how we can follow tracers that go into that region. So yes, they've been doing it in animal models. Some beautiful radiofluorescent. In fact, the ACE2 work on that was using some of those beautiful markers and tracers, which is really quite stunning.
Okay.
Hi, Nick.
Yeah, I have a question. The finding that you presented with the reduced volume of olfactory bulbs in the area around them caused by SARS-CoV-2 reminded me of mesiotemporal sclerosis, which is reduction of the volume of hippocampus, and one of the reasons for it could be viral pathogenesis. So my question is can it be some correlation between the pathophys of this reduced volume regarding these two viruses, and have you done some more research related to herpes viruses and mesiotemporal sclerosis?
Absolutely. That is our next area of research. So I 1000% agree, because we really don't know, right? Everybody assumed it was from the temperature. When people get mesotemporal sclerosis, it was often a viral infection, right? The high temperature, they think it's because it's more of the temperature patients have an immune response, but we don't really know, right? So I do believe it's the interplay of the viruses. What's interesting is we're actually now mapping and doing quantitative mapping of where these fiber tracks go, because they're going to track along the viral fiber tracks going into the brain. And so clearly, if you have a rapid transmission of a viral particle coming into there, how is it interplaying with that temporal lobe and that region? We know it's affecting the ARC2 protein. We know the temporal lobes get affected, but if I had the answer for that, I'd have the Nobel Prize. But it's a great area for research, and it's something that I firmly believe is going on. I think we also know that we can find, we don't really see a lot of viral particles in the brain when we look at COVID pathology and autopsies, but we do see them into the hypothalamic region, and those small nervus terminalis fibers with kisspeptin neurons go to the hypothalamic region. So we know that it's two ways, right? It can go through the bloodstream, either in the CVO organs, which lack a little bit of the blood-brain barrier, or along these viral pathways. So we're now mapping, and we're doing quantitative mapping of these pathways, because I think it's really important to understand how it's getting there. I think it is critically important for research. And I also will say that, as the population ages, we know that, over 7 million people died from COVID, but over 700 million people were infected, right? I mean, just insane numbers of people that we know of infected. Some people are infected, didn't even know it. And we know that long COVID is going to occur in about 1/3 to half of those patients with dementia-like symptoms over time. So that's a really critical thing for you guys to think about. There's going to be a lot of long COVID patients. Some people get it, some people don't. We don't know why. I do think, again, diabetes, obesity plays a key role, but we don't know those mechanisms. So it is a very fertile ground for research, and firm believer that we are yet to, map out those intricacies of the temporal lobe. I personally believe that there's absolutely probably a viral component, and they're now believing that there may be, for Alzheimer's and some things, reactivation of some of these viral components within the brain. Like they're in us all the time. We know if we reduce our immune system, you get the JC virus. We have a lot of viruses in us all the time. What's really fascinating to me, and most people don't think about, when we look at dementia or Parkinson's or any of these things, the first and most important sense to be involved is olfaction, yet we don't really study it. Right? The first thing that goes in an Alzheimer's patient is their loss of smell. Same thing in a Parkinsonian patient is their loss of smell. Many people don't even know that, but it's that's the first thing to go. And we also know in patients who get very depressed and we're suicidal, when you lose your sense of smell, you can get very, very depressed. The In Excess drummer, people don't realize he had a trauma. He literally sheared his olfactory tract and bulb, and then he committed suicide. So it's a really important sense, but we don't even know how it works. So I have my theories on that. That I'll have to hopefully work. That's another paper I'm working on. So I'm literally going to finish and then start cranking, have meetings, and then keep working away. So much to do.
Thank you very much for your comprehensive answer, and for your lecture. It was eye-opening. I'll definitely devote more time into reading some of your work.
Oh gosh, well, feel free. I love teaching, and I love if I inspire one of you, and you guys beat me to the punch, I'll be ecstatic. You help understand those mechanisms. I'm sure you will, because you guys are all brilliant. But you know, in future work, I'm sure you'll do amazing work as well. So, hi, Nazanin. Nazanin.
Hi, Dr. Kirsch. How are you?
Oh my gosh! Oh my gosh!
Oh, good to see you again.
Oh my gosh! Yay, Nazanin! Oh, she used to be here, yeah, but now she's with you guys, so we're so sad. She's amazing.
Thank you. You're the amazing one. So I just wanted to share my thought. So today's lecture, it resonated with me on so many levels, because actually my interest in neuroradiology is deeply, I was influenced during my experience when I was visiting patients during COVID. And I encountered patients in the ER presenting with strokes, with like the first presentations of like seizure, meningitis. And that's how it shaped my path coming into neuroradiology and working with Dr. Boya and you. And another thing I wanted to say was, again, our involvement with the PD-L1 trial on squamous cell carcinoma. So I spend weeks in tumor boards seeing patients with specifically like HPV positive squamous cell carcinoma, of how they behaved so differently. And so we had a patient, my question is, we had a patient and she presented with, metastatic squamous cell carcinoma, HPV positive, but she was, and they found it like very late, but she was presented, like she visited ENT doctor like numerous times with this presentation of like a discomfort in her like left nasal cavity, like this area.
Yep.
But nobody could they couldn't go and biopsy, because they didn't know where to biopsy, and it was, so my question was
HPV phenotypic, I have to tell you, we have literally now a collection of exactly those same cases, because people can't believe it's HPV in the sinusal cavity causing this. Normally, you think of like a inverting papilloma or papillomatous type lesions, but we are seeing these more aggressive subtypes, which often have perineural involvement, and people thought they were adenocistic, but they're actually viral related. So we see what we know, right? We're now being able to go back, and we're going back. And here's the other thing. The literature, I always look a little bit skeptically, because people previously reported these cases before they did the immunohistochemical staining or testing for the HPV in the sinus, called them adenocistic, because they look and mimic the appearance of an adenocistic, but it might have been a multiphenotypic what we call multiphenotypic ACC, really HPV related. So the WHO is still evolving as we look at these tumors, but we're finding now that many of these are actually probably viral related. We just weren't checking or looking for it before, and they can be very aggressive, unfortunately. And unfortunately we find them sometimes later, which is very bad.